So CaO2. So we know that the little a means in the CaO2 arterial, right? So if it's a big A, we mean alveolar, right?
Yeah.
So the little a means arterial, and we know O2 means oxygen, right? So what does this C stand for? And that's really just talking about the capacity. So how much of that oxygen is on or within that blood, within your arterial blood. So we need to have our hemoglobin, how saturated our hemoglobin is, okay, because that's going to tell us how much oxygen's in the blood, right? And then this is how much is dissolved in the plasma. Do you remember talking about some of those? We're like, oh, in the plasma, it's like 0.003. It's not really a large amount of oxygen that's being housed in that plasma. The majority of it is in the hemoglobin. And remember, we said it's about 1.34 if it's completely saturated. Okay, that hemoglobin is completely saturated. So this over here is telling us how much oxygen is attached to our hemoglobin. And this over here is telling us how much is dissolved in our plasma. And then these two together are going to tell us the carrying capacity that is happening within that arterial blood. Does that make sense? How that's happening? So it's the total content of blood that's equal to the total content, oxygen content of blood is equal to the volume of oxygen physically dissolved in the plasma plus the amount chemically combined with hemoglobin. And this is mathematically into this, this equation. And our normal is 16 to 20, okay, milliliters per deciliter. So why do we care about this? Why is this even important? Obviously, it's going to show us the amount of unused oxygen by the tissues and returned in the venous blood. So we know, oh, that's CVO2, sorry. I was like, wait a minute. It's going to tell us how much of oxygen is being carried in the arterial blood to meet the tissue needs. So obviously, if our patient has a low hemoglobin, if they're low as far as their hemoglobin numbers, is their carrying capacity going to change?
Mm-hmm.
Potentially, depending on how low it is, I guess, really. And now also the saturation, right? So if it's completely saturated and we have a low hemoglobin, that does kind of balance it out a little bit. But it just depends on how low that hemoglobin goes, okay? So let's do one together. Okay, so first, our PaO2. Is that something, how do we get a PaO2? Where do you get that from? An ABG, right? A blood gas, okay? So if you don't have a blood gas, you can't get that, right? I can't use SpO2, whatnot. We have to have a blood gas, okay? So I will be giving you that information. So we'll say our PaO2 is 75, and I'm just making all of this for you guys, okay? So 75, and so you times 0.003 plus hemoglobin. What's a normal hemoglobin range? Do you guys remember for males or females? Yeah, like 15 could be for females. It's like 15 to 20 or something like that. So we'll just go with 15, okay? So hemoglobin is 15 times 1.34. And we'll say our SaO2, how do I get that? Close. So SpO2 is the pressure, right? So SaO2 is the saturation that you get from an ABG. So you should get that from an ABG as well. If it has a little a, that's where it's coming from, is that ABG, the arterial blood. So we're gonna say, we're gonna give it a 90, okay? Okay, so first, I want you guys to multiply 75 times 0.003 and tell me what you get. .225? Concur? Okay. 0.225. Now take 15 times 1.34 times 0.90 because this is a percentage, right? The saturation.
18.09.
Say it again.
18.09.
18.09, and then add those two together, 0.225 plus 18.09. Say it again.
18.315.
Say 135.
315.
Okay.
So you just rounding it or no?
So you can say 18, you can say 18.3. I wouldn't round it down, or, I mean, I wouldn't do much with it. You can just do 18.3, that's really fine. Or 18 is fine too. I wouldn't round like up to 19 or anything like that. Okay,
Oh, yeah.
so what is our normal value?
16 to 20, so yeah, that's.
So it's normal, right? Okay, so this is normal. Now, one thing I want to point out, what was our PaO2? PaO2. 75, is that normal? No, 80 to 100 is normal. So this was actually low, right? So we had a low PaO2, but we did have a normal hemoglobin and somewhat normal saturation, a little low, but 90. So those two were not that far off, okay? And that's not super low either, right? So you can see how it can still be normal with some of that low PaO2, because that's really just telling us currently what their oxygen status is. So it's not making a huge difference. Does that make sense?
Yes.
Okay. All right. So how do you feel on this one? Pretty good? Okay. Now again, the ones that we will be given to you are going to be SaO2, hemoglobin, because you have to draw blood for that as well, and PaO2. So these other ones, you'll have to memorize, the other two. Okay. Those are the values that you'll have to memorize on your own. Okay. Moving on. Where's my clicker? Okay. So I'll let you guys maybe do this on your own. I just want to make sure we get through everything. I'd rather skip that, and then you guys can do those on your own, the practice ones, okay? Okay, so the most influential variables are the hemoglobin concentration and the oxygen saturation of that hemoglobin. So we just kind of figured that out just even doing this one, right? So the hemoglobin concentration, so the 15, right? And the saturation. Those two make up a bigger difference and made this normal, even though we had a low PaO2. So these are the big factors here, okay? Also because, remember, hemoglobin is it's kind of the bulk of where our oxygen is going to be in our blood, right? This is kind of a very minuscule amount that dissolved in the plasma. This is the bulk, okay? Okay, so now we're going to take the same exact concept and we're going to apply it to our venous gas, okay? So a CvO2. So it's the total calculation of oxygen content in mixed venous blood. So where is the blood, where is this blood obtained and why? Where are we getting this from? It's a vein, it's a vein. So it's no longer the artery, we're looking at the vein, okay? So why do we care about this? Why we know what the CaO2 is, that should be fine. Why do we care about the CvO2?
Because it's the oxygen in the tissues.
Yeah, it's gonna show how much oxygen was used. So how much oxygen was given, the tissues took, and how much is left over, okay? So if we have a huge difference, we know that a lot of oxygen was potentially used. If it's smaller, not that much wasn't used, right? So maybe that we might have some hypoxic tissues, okay? Or we might have a shift of some sort. So same exact concept, except you have a PVO2 and an SVO2. Same exact equation, you're just plugging in the venous values, okay? Do we need to do one of these? Or do you guys feel good because it's the same?
It's the same exact thing.
It's the same exact thing, just venous gas. So you'll be given SVO2, hemoglobin, and PVO2 instead of PaO2, SaO2. Make sense?
Mm-hmm.
Okay. So the really important thing though about this is once we obtain this and we have our CaO2, oh, these are normal ranges. So for our oxygen in general, so oxygen content. Oh, hemoglobin content, okay. These are just normal values, so. But the difference between the two, the AV difference, is really what we're looking at. So remember, if we take our CaO2 minus our CvO2, it shows how much of the quantity of oxygen was extracted by the tissues. So the AvO2 difference is really what we're looking for to see how well our tissues are being oxygenated. So kind of a big deal, right? I mean, that's a huge deal. We want to know how much of the oxygen is going to our tissues. Okay, so the normal for this is about 3 to 5 volume percent. So that's what the difference should be, okay? 3 to 5 volume percent. Where's an eraser? There they are.
3 to 5%.
Yes,
Okay.
3 to 5. Per 100 mils of blood. Okay. So next we're gonna get into this mess of things, the oxyhemoglobin dissociation curve. So it sounds like you guys know a little bit about this, right? Dr. Krager's gotten into it.
With the chart, we don't really go fully into it, but yeah.
Okay, well, let's do it. Okay, so can you tell me, what is the importance of this graph here? Who can tell me? It's okay if you can't.
You can't.
Okay. She's like, I'm just gonna speak for who we can. Okay, so it's really, you look at the first point here. It's a graph that illustrates the percentage of hemoglobin that is chemically bound to oxygen at each oxygen pressure. So let's break that down. So we have hemoglobin on this side, okay, and it's the saturation, okay? And then down here is our PO2, our PaO2, so the pressure of oxygen, okay? So that's that's in our arteries. That's what we're trying to get, that PaO2. That's all this is saying, it's that pressure, okay? So this is down in the artery, right? And this is the hemoglobin in the arterial blood as well. So we're talking about the saturation. So not the number of hemoglobin. This is our SaO2. SaO2. Does that make sense? So we're looking at how saturated the hemoglobin is at a certain pressure within the arterial, a certain PaO2. Okay? So if I'm at a PaO2 of 50, and I should have a saturation of about 85, if I follow this up, okay? So remember, 60 is 90. 60 and 90 go together. So this is that slippery slope we kind of talk about. But if you take this, a PaO2 of 60 should have a saturation of about 90%, okay? That's a healthy individual. That's someone that doesn't have any kind of issues going on. So that's how we're reading this, if that makes sense. So a PaO2 of 60 should represent a saturation of about 90, okay? So when we're talking about that, that's what we're looking at. PaO2 versus the saturation of that hemoglobin. So our SpO2 is pretty similar to our SaO2. So if our SaO2 is 90, our SpO2 is probably about 90. Because that's what it's reading, really, right? Is the pressure of the oxygen. Does that make sense? So it's looking at the saturation, but using pressure as far as our SpO2 goes. And so it should be very similar, if not the same, as our SaO2.
I wondered how that thing was actually reading like that.
It's just reading pressure. That's why,
I
yeah.
was wondering that.
That's why when we have anything that's bound to it, our hemoglobin, it doesn't know what it is. It's just like, oh, it reads the pressure, and it's like, oh, it's filled with something, and so that's, yeah.
It's assuming. Okay.
Yeah.
Okay.
So, if we have a PaO2 of 60, we should have an SpO2 about 90, okay? All right. So, the S shape with the steep slope from 10 to 60 millimeters of mercury is that steep slope. So we're talking about right here is our steep slope, and the flat portion from 70 to 100. So, okay, oh, right here, 70 to 100 is our flat, okay? So when we talk about the steep slope, we're talking between 10 and 60 millimeters of mercury as far as our PaO2 goes. And for our flat, we're talking about 70 to 100. So the slope, 10 to 60, shows that O2 rapidly combines with hemoglobin, meaning that it increases very drastically, okay? Depending on the percentage, it can be very little amount of oxygen binding, and it increases our PaO2 drastically, okay? That's why it goes up quick. So when you come up to that flat portion, it starts to even out. So even if you apply or have more oxygen added to our hemoglobin, it's not making a huge difference. You're going up by just a little bit during that flat portion, okay? So when it comes to this up here, you're gonna see a very small amount of change given whatever oxygen we give to that patient, whatever it binds to the hemoglobin. Does that make sense? So this steep slope, you're gonna see oxygen combines quickly and our PaO2 increases quickly. Once it comes up here, our PaO2 may not increase by very much. It's just going to be, it's gonna kind of slowly go at this flat, more plateau-ish range until it reaches 100. And then it doesn't go above 100, right? We can't have more than 100 as far as our PaO2 goes, right? We shouldn't. So that's kind of in a nutshell what this is. Now we're going to talk about the shifts, but does everyone kind of understand a little bit as what this graphic means and how to kind of read it? So if I say your PaO2 is 50, now what is that? If our PaO2 is 50, what range is that in? What kind of hypoxemia do we have? Mild, moderate, severe? Moderate. It's moderate. So if I go up, follow this up, it should be about 85. Our PaO2, or I'm sorry, SaO2 or SpO2 is 85, okay? So that's really all we're looking at what pressure our PaO2 is and what our SaO2, SpO2 should be at that given pressure.
So all we have to do is be able to read the chart. You know, we don't have to like memorize that chart. They're gonna be like at 50, this is what it's at. You know, I just have to read that chart.
60 and 90 are a good one to memorize.
Okay.
60 and 90. Now for my class, no, you don't need to memorize any.
Because I can read, I know the read chart, but I'm like, maybe I can't tell you right now I don't memorize them. I don't have them memorized.
In my class, you don't have to have them memorized. I think, I don't know, I can't speak for Dr. Figures, but my class, no, I really want you to understand what this means, and then also when we go to the next slide and talk about shifting, what that means, okay? So this is a normal chart. This is what you and I all have because we don't have any other issues going on, okay? So it does have a shift to the left and a shift to the right. And our body does that at different times too, because that's what we want to happen within our body. So it can be for good and it can be for bad, okay? So we'll talk about that. Any questions about that?
Yeah.
Yes.
True. So this is showing us how much oxygen is going to our blood,
So this is how much is in your blood.
how much is in our blood.
And then
Okay.
this is the saturation of hemoglobin.
In the arteries?
It's
The
all
bottom?
arterial, yes.
Yeah.
All arterial. Now I say the SpO2 because it usually correlates or is the same as this SaO2.
Okay.
Because they're both talking about saturation of the hemoglobin. But the SaO2 is much, okay. The SaO2 is more accurate.
Okay, and then, so do you want us to know, like as a, if we had a question, we would have to identify if it's mild, moderate, or anything like that? That's the question you just asked us.
The hypoxemia,
Yeah.
we should have that already, right? Have we talked about that? Yeah, that should be something you should know. So that would be, so
Yeah,
remember
let's go
80
over.
to 100. So this is just PaO2. 80 to 100 is normal. And then we have our, so technically 79, but I usually just say 80 to 60 is mild. And then 50, wait, right? Hold on.
And this is for the PaO2?
This is for PaO2. So 59 or 60 to 40 And then anything less than 40, severe.
I'm glad you're right. I don't know.
So this can be 59 or 60. I'll just write 60 to stay the same as my other one. So these are just PaO2 and talking about hypoxemia. Does this look familiar to you guys?
Yeah.
Okay.
Like the mild and the moderate. I feel like, you know, on the sauce, it always gets me like,
So they
to
go-
me, it'd be like same.
So they go down by 20s, if you look
Okay.
at it, right?
Mm-hmm.
Okay.
Yeah, I like that chart, thank you.
Yeah, you're welcome, of course. Okay. So there is one that I do want you guys to kind of be familiar with, and this is the P50. So this is when your PaO2 is at 50, meaning that it's, let's look here. At 50%, remember we talked about it being kind of at 85? But when you have a PaO2 of 50, it also means that your hemoglobin is technically 50% saturated, okay? And that can mean a huge difference as far as our overall oxygen saturation, but also if it's gonna cause a shift or not, okay? So normally the P50 is equal to about 27, oh, this is talking about, sorry, I said the P50 down here, this 50. Is talking about 27% PaO2. That's quite low, right? So that means you are at 50% saturated as far as the normal individual goes. So P50, even though it says PaO2, we're also talking about the actual hemoglobin saturation. Okay, so it's the PaO2 of 27 that's equaling the SaO2 of 50%. So hopefully that makes sense.
PaO2 of 27.
Yep, is equal to 50% saturation on that of hemoglobin. Okay? So, but there are some abnormal conditions that can cause a shift of the curve to the left or the right. So this, at this 50% P50 is usually kind of a slippery slope. So if you are already at that 50% saturation, if you have any small change within the body, with the things we're going to talk about, like pH, temperature, acidosis, those types of things, it will drastically change and cause that shift, especially when you're already this low, okay? So P50 is going to be a larger partial pressure is going to be needed to maintain that 50%, okay? So if we don't have a change in oxygen by increasing it, we're going to have a shift to the left or the right, essentially. Does that make sense? A little bit? So this slippery slope of P50 means that if we don't give oxygen an essential amount or a large amount of oxygen to our patient, we're gonna probably have a left or right shift, depending on the patient's status, okay?
A larger partial pressure is needed to maintain that percent?
Yes, than the average. So how do we increase the partial pressure? We increase FiO2, okay?
Can you say that one more time?
Yeah. The P50 means a larger partial pressure is needed to maintain 50% saturation.
And then without the 50% saturation, there's a shift to the left.
Mm-hmm. So if it shifts to the left or the right, you know, it just depends on the situation. But we are going to obviously need to increase our FiO2 to help overcome whatever shift we have. Okay. So if we have an increased P50, that means we are going to have a shift of the oxyhemoglobin dissociation curve to the right. So if I say increased, P50. That means it's going to increase and shift to the right. And why do I say increased P50? It's shifting to the right. So what's happening to our PaO2?
It's getting bigger.
It's going up. So the PaO2 is going up, right? If we're shifting to the right, we're actually increasing our PaO2, okay? So increased P50 equals a right shift, okay? Ultimately increasing the PaO2. Okay. So, even though we've shifted to the right, it can be for the good or for bad, right? So our body does shift to the right, because remember, right releases, right? So lefty loves and holds on tight. Right is gonna get rid of the oxygen, okay? So if we have a patient that has an increase in temperature, our tissues need more oxygen. We're burning through it. Now, sometimes we aren't able to keep up with that, right? And we'll have to give supplemental O2. But in this case, if your body is needing the oxygen, it shifts it to the right for a reason, to get rid of some of that oxygen, okay? So, righty releases, so decreasing hemoglobin affinity for oxygen. So affinity means the hold. Okay, so if we're decreasing that affinity to the right, that means we're releasing oxygen to the tissues. We're decreasing the hold, that hemoglobin, that chemical bond between the hemoglobin and the oxygen is being broken down, and we're releasing that oxygen, okay? And we want to, okay? We want to release that oxygen. Now again, sometimes we aren't able to keep up with the demand, and we will have to increase our supplemental O2, okay? Which is totally fine in the situation that we have. Now, when would we want a right shift? A right shift in our bodies. When would we want to release oxygen? In the lungs? Do we want to get rid of oxygen in the lungs or the tissues? The tissues, right? So our body actually has an anatomical shift to the right at the tissues. So it's like, okay, I've hit the tissues, release, 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 get rid of the oxygen. We want that to happen, right? So then at the lungs, we don't want to get rid of the oxygen, right? So we shift it to the left, and our affinity increases, and we're just getting oxygen and holding on to it in our lungs so that we can hold on to it and take it and carry it to the rest to the tissue when we're ready. Does that make sense? So the shift happens when we want it to in the body, naturally, okay? But there are some things that cause it to shift when we don't necessarily want it to, okay? And those were some of the things that I listed. We're gonna go over them too, but that was on your cheat sheet. Some things when it's good, sometimes when it's not good, okay? So when we have a saturation of 50, increased P50, we're gonna shift it to the right.
So at the lungs, you wanna hold the oxygen, at the tissue, you wanna release.
Yep.
So it should go to the
Right,
left.
should be left.
So it should shift
At
to the
the
left,
lungs.
at the tissue, at the lungs, and then
Yes.
right in the tissues.
Okay.
Okay. So that's really what this is saying as far as our increased P50. So we're talking about the increase in our hemoglobin saturation, okay? It's going to increase that, and it's going to increase our PaO2, okay? When we shift to the right. Okay,
Say that one more time. I heard you, but I just
That's okay.
was writing too.
that's okay. So when we shift it to the right, we are increasing ultimately our PaO2.
Okay.
And so that's ultimately why we call it an increased P50. But we also substantially could be, we're just shifting the 50% over, if that makes sense, to increase our PaO2. Now, for us to increase our saturation, we're probably gonna have to give supplemental O2 at this point. Does that make sense? But an increased P50 shifts to the right, increasing our PaO2. Okay? But we're also releasing more oxygen. That's why our PaO2 increased. Does that make sense? For your PaO2 to increase, you have to be releasing that oxygen. Okay. Now that we've got shift to the right, a P50, a decreased P50, is gonna be a left shift. Lefty loves. So ultimately, if we shift to the left, we're going to decrease our PaO2 because we're increasing the unloading of oxygen, okay? So our body's burning it up, our body's using it. Does that make sense? So if we shift to the left, it's that chemical bond is breaking to where it's getting rid of all of it, okay? And it's no longer trying to hold, wait, I'm so sorry, lefty loves, I'm so sorry. Lefty holds tight, I'm so sorry. So the infinity is increased, so it holds on to that oxygen. So it's going to hold on to it, and it's not going to get rid of it. That's why our PaO2 decreases. Does that make sense? Because it's not allowing the tissues to have the oxygen. It's holding on to it. Lefty loves, righty releases.
You said that's why the PaO2 decreases because it doesn't want to get rid of it?
Yes, it stays on, and it's not letting go. So our PaO2 ultimately decreases. So this is going to be from 27 millimeters of mercury that we talked about, that P50, down to our 10, okay? That is the range of our shift to the left. So it results in an increased hemoglobin affinity of oxygen, increased loading of the alveoli, okay? Oh, at the alveoli. So this is when we shift to the left and at our lungs, right? So affinity, the hold increases. This is at our tissues. And this is at our lungs. Yes. Yes, of course.
How do we know that where it's at, like the tissues or the lungs? Like, just based
Say it
on the
again.
curve. How do you know that it's at the tissues or the lungs?
So you just
based on-
assume, like, that's what happens.
Because of the shift.
Yes, I mean, the shift is just happening. You don't have to necessarily look at the numbers and say, oh, it's obviously shifting to the left, it's in the lungs. I mean, that would just be, there's just an assumed thing. So it's just to know it, know
Okay,
that
so
that
it's not
happens.
that from 27 to 10, you would probably, if you could see it go from 27 to 10, you would know?
No, not necessarily,
Okay.
no, that's just talking about the decreased P50.
Okay.
Okay, so not necessarily, oh, that's in the lungs.
Okay.
Does that make sense?
Yes.
Okay, we're just talking about that 50% hemoglobin being saturated and how that shift, it can be drastically changed just by shifting left or right. So if you're already only 50% saturated and you shift to the left, holy cow, what a low PaO2 that is. Now we're 27 to 10 millimeters of mercury of PaO2, that's extremely low. If you shift to the right, you'll see that we have an increase in PaO2. Okay, so just seeing the difference in that shift and how that 50% can be huge. So if you don't have a fully saturated hemoglobin, shifting left or right makes a big difference in our PaO2. And that's why that's kind of a big deal as far as our saturation and the overall content of oxygen in the blood. Does that make sense?
So decreased P50 is decreasing the PaO2? Which
Correct.
will give us a left shift. Okay.
The decreased P50 is the left shift.
Okay.
And it's decreasing. That's why our PaO2 decreases. Does that make sense?
Yeah.
Yes.
When we're like reading these charts and look, do we need to have a baseline? Just like, how do we know that the shift, because they're still, all the lines are going the
So
same
this
way?
so the shift, yeah, you would have like a normal.
Okay, so you'd start with like a baseline and then you do the math to figure out.
Yes, you would
Okay.
see it would. Usually, my questions will be like a shift to the left or the right could be caused by what?
Okay.
Really, and this is more of an in-depth, just so you guys
Like a
understand.
decrease in P50? Is that kind of like?
We haven't gotten there yet, so don't
Is
stress.
that kind of answer?
Yep. But no, this is really just to show you the different,
Okay.
and P50 is a very well-known saturation of hemoglobin, and understanding that a slight shift to the left or right makes a huge difference in that patient's PaO2.
Okay.
And so when we know we're at P50, are we gonna need a supplemental O2 to help overcome that partial pressure? Absolutely, and increase it. Okay. So shifts of the oxyhemoglobin dissociation curve. Various substances affect the shape of the oxygen hemoglobin dissociation curve. it's a mouthful. Shifting the position of the curve alters the binding capabilities of hemoglobin, which we know, right? We shift to the left, it's gonna hold on to it, lefty loves, shifts to the right, righty releases. So we know that bond kind of changes, right? Shifts to the right decreases the affinity, shifts to the left increases the affinity. So that's the hold, remember? Okay, effects of the pH. So we're talking about pH now. On the oxy, hemoglobin dissociation curve. They need to come up with like a acronym, right? So, pH. When we're talking about pH and I say a decrease in pH, what does that mean? Is it more acidotic or is it more alkaline?
Acid.
Yes. So a decreased pH equals acidosis. Okay. An increased pH then means more alkaline, okay? So this would be, let's see, you're less than 7.35, right? And this would be greater than 7. See? I put a 7 in there.
7.45.
Yes. Okay. So that's what we're talking about right now. So if our patient has a decrease in pH, we are going to it's going to cause a shift to the right. Shift to the right. Righty releases. So we have an acidosis. So our patient is going to require more oxygen. So our chemical bond is kind of weakened and it's saying, okay, like just take this oxygen, just whatever, you need it, get rid of it. So that's why it shifts it over to the right, okay? So you can see here 7.20, it's pretty acidotic. 7.60 does what? Shifts it to the left. So an increased pH causes a shift to the left. And lefty loves. So our affinity goes up. The hold goes up. So a pH of acidosis shifts it to the right. An increased pH of alkalosis shifts it to the left. Okay? Okay. Next, we're going to talk about temperature. So, and let's just do this. We'll do this. We'll do a shift to the right. We'll make a list. Right. Oh, we should probably just do it to the like left and right. Don't you think that makes more sense? All right. If you're going to be logical about it. Okay. So we said an increased pH does what? Shifts it left or right?
Increase goes to the left.
Increased pH goes to the left because that's alkalosis. So that means a decreased pH goes to
The right.
okay. Temperature. What do you think an increase in temperature would shift? Which way does it shift?
It's gonna go right.
To the right, yes. So increased temperature goes to the right. Because remember, when we have a fever, what happens to our O2 demand in the body? It increases. So our body's burning through it. So usually those patients that have a fever require supplemental O2 because their oxygen demand is higher. Okay? So it shifts to the right to get rid of it and release it because it needs it. Okay? That's good. We want that. Our body needs it. Okay? So then a decreased temperature is going to cause it to shift to the left. Decreased temp. So we want that, right? Our body is really cold. Have you ever heard about those patients that are found in like the frigid cold and like they survive because it slows everything down. Everything slows down, so does your oxygen demand. So it shifts it to the left because it's not needed at that time. Our body's decreased, our temperature's decreased, so the O2 demand is decreased, our metabolism's decreased, respiratory rate goes down, heart rate goes down, everything goes down. And so that's why it shifts it to the left with a decreased temp. Okay? Okay. PCO2. So we're talking about CO2. So CO2 and pH kind of go hand in hand, don't they? So if I have an increase in CO2 in the blood, what does that do to my pH? Does it make it more acidotic or more alkaline? What'd you say? Acidotic. So if I have more CO2 in my blood, what does it do to my pH? It makes it more
Lower.
acidosis.
And it's gonna go to the right.
So it's going to shift to the right because my pH went down. Does that make sense?
Yes.
So the higher the CO2, the lower the pH. Yeah?
Mhm.
So we already know the low pH is at the right. So we know that an increased CO2, PCO2, is going to be a shift to the right. What?
Lowers pH. Increase CO2 lowers pH.
Correct. So then we ultimately know that a decrease in CO2 causes an alkalosis as far as our pH, so it's going to shift it to the left if we have a decreased PCO2. All right, now we're on to something.
Increase.
Are you guys getting those blanks filled? I'm sorry, I'm just kind of shouting it out. Okay. So I did make a fun little list for you guys here too, so don't worry. But there is one we didn't talk about, and it's the increase, it's a 2,3-BPG. And that is a chemical that is actually helps bind oxygen. So if you have an increase in it, it hold on, I gotta think about this. If you have an increase in that chemical or that, it's a chemical bond, then it is going to release that CO2 or that oxygen to the blood. So remember, righty releases, so it's shifting to the right. So an increase in that is going to cause that bond to break down, that bond to break down. So it releases it from that hemoglobin a lot faster. Okay, so this is something that if you have a lot of it, it's going to break the bond down. If you have a little bit of it, it's going to not cause a change in that bind, and it's going to hold on tighter. Okay, don't ask me what BPG stands for. Google it. All right, so shift to the right, increased 2,3 BPG. So then if I have a decrease in that, it will shift to the left. So there's a few other things I added here because we talked about them earlier. But remember, we talked about increased carbon monoxide poisoning. Well, that actually shifts it to the left. So what's going to happen is we're just going to hold on tight to all of that oxygen. The oxygen we do have, and whatever carbon monoxide we have, we're not releasing it to the tissues. And then also that's how our fetal in utero, remember we talked about it holds on to the oxygen because it's getting nutrients from the mom, it doesn't need it. So that's kind of how their hemoglobin is, that special hemoglobin, that fetal hemoglobin. And then that hemoglobin is another one. Remember we talked about the blue people, right? Mm-hmm. And then that is another one that will shift it to the left. Okay, so if I shift to the left, what happens to my oxygen? Raise your hand. I can't remember who went, one of you went first, but.
Go ahead.
Go ahead, Cammie.
It holds on to the oxygen
Lefty loves, right? So it's gonna hold on tight.
in the heart.
Yes, so the affinity goes up. If I shift it to the right then,
The affinity goes down.
the affinity goes down and we're readily releasing that oxygen to the tissues. Okay? Okay, and that PaO2 correlates with that. So if it shifts to the left, it's gonna decrease the affinity. It's also going to, increase the affinity. So then it's going to, they're inversely related. So then it decreases the PaO2. Okay? All right.
Right, because the right shift decreases the infinity. And then
Correct.
the left, okay. Make sure that's right.
Okay. Any questions on that fun little thing? We got a little bit more here, but okay. So shifts of the oxygen hemoglobin curve, right helps link oxygen to the tissues. It helps to give, release, whatever you want to say there. Give, release, a shift to the right releases that oxygen to the tissues. And then left helps oxygen hold load on the hemoglobin. okay? So when we go to the lungs, if you think about it that way, we have that shift to the left. So it will load the oxygen on the hemoglobin, then the tissues, there's a shift to the right to get rid of that oxygen, and then it just keeps going around and round and round. Okay, I have important reference points, but I don't expect you to necessarily memorize these, except for that 60-90 is a really good one to remember. So at 30 millimeters of mercury, PaO2, our SaO2 should be 60% saturated. Okay, our hemoglobin should be 60% saturated. And this is just going off a normal oxygen dissociation curve. These are the numbers that would be considered normal. So our normal value, okay? So at 30 PaO2, we should be at least 60% saturated, okay? At 60 PaO2, what is the percentage saturation? 90. So if you look at it, do you see a trend here?
They're 30 apart.
Yeah, they're 30 apart. So then 40, 70. So add 30 to 40 is all you're doing.
Oh, I thought you were to the 6. I'm like, that doesn't sound right. I'm like,
You're like, wait a minute.
that's not.
So 40 plus 30 is 70. So the percentage, the SaO2 should be 70. So what about 27? 50. That was the only weird one, right? And then 80 to 100 is 95 to 100. And if we have a PaO2 of greater than 150, it's just gonna be a saturation of what? 100. We can't get any more saturated than 100%. Our PaO2 can go up, even though we don't want it to, it shouldn't, but our saturation never goes above 100. So this should say 60, 90, 70, 50, 95 to 100, 100.
What is indicated when the PaO2 goes up? The pass.
What is indicated? Say it again.
With like the PaO2 going up? For like above 50? Or above 150?
They're just getting supplemental O2.
Okay.
So someone's on oxygen. That's the only way you can go above 150.
Okay.
And they're getting too much oxygen. So that would be overcorrected oxygenation. You can say hyperoxia. You can say those types of things, like when you interpret a gas, which we'll talk about next semester. But yeah.
Okay.
Okay. In the literature, in a survey of 30%, this is just FYI for your information, 30% of physicians and 90% of nurses thought that pulse oximetry measured PaO2. What does pulse ox measure? SpO2, which is what? Saturation of our hemoglobin, and it's not even super accurate, right? I mean, necessarily, depending on if you have any of the other factors going on. So they think that that's PaO2. That's not the case. In fact, we really should be getting a PaO2 if we're really worried about oxygenation, right? That's kind of that's the meat and potatoes. In the same survey, many doctors and nurses stated they were not especially worried about patients with SpO2 values in the low 80s, equivalent to a PaO2 of 45. What's a normal PaO2? 80. That's like extremely low, right? So they may not quite understand what it means for that saturation to be in the 80s, but we do. And that's why we are the ones that really should be advocating for our patients. That's what this is saying, that's not their wheelhouse. I mean, they need to know so many different things, and we do too, but we focus on oxygenation and how oxygen works in the body and what it means. So this is kind of where we need to be like, well, if you actually look at it, that means that their PaO2 is probably around 45. It's not 80. You know, it's not what the SpO2 is saying, which they might think, okay? So that's something that we need to advocate for and understand, okay? That's all that was for. And it's not to say anybody's stupid, right? That's just not their wheelhouse, right? That's us. That's why we are who we are and what our position that we have in the clinical setting. Okay. So, when I say P50, what am I talking about? P50,
Saturation
Saturation 27.
of the,
not the saturation 27, what's 27? What is the 50 representing?
the P50 saturation of the.
So the hemoglobin's 50% saturated, so then our PaO2 is probably around
27.
27. And also, what do we need to, if this is happening, what do we know about our patient? They're gonna need what? Supplemental O2, right? Supplemental O2. And the normal PaO2, what's the normal P50? And it's just 27 is all I was looking for. 27 milliliters mercury, that's the PaO2.
What's the 27 again? Sorry.
That's the PaO2. So I mean, if you're drawing an ABG and you're looking for oxygenation, that would be severe hypoxemia, right? Extremely severe. If there was extremely severe, that would be the label, but there's only severe, so. Okay. And what is the significance of this measure? Remember, when we're at that 50% and we don't provide any kind of supplemental O2, we're gonna probably have a shift, right? It's gonna start shifting. So we need to overcome that, that 50% saturation by applying that partial increase in partial pressure. How do we do that? Supplemental O2.
Just to confirm for my number one, they're gonna need the P50, the saturation of the oxygen, well, the hemoglobin,
Mhm.
and then the normal of the 27, and their severe hypoxemia, and they're gonna need supplemental O2, or they're gonna have a shift.
Correct,
Normal P50 is 27.
correct. The PaO2,
Mm-hmm.
that's what I was looking for there. Okay, so this is a circle situation, but I'll tell you so you guys can know it's hard to read those. So, shifts of the oxygen dissociation curve to the left causes a blank, so either increased or decreased affinity. So to the left, lefty loves.
Increase.
So what does it do to the affinity?
Increase.
It increases affinity. Because affinity is the hold. So
Oh, yeah,
if
yeah.
lefty loves, it's going to increase affinity. Okay, that's that first blank. So the next line says, when shifted to the left at any given PO2, so that's the bottom number, the SaO2 or SO2 will be blank than the normal in the tissue, than normal. So what happens to, it says either higher or lower, sorry I didn't say that part. So what happens to the SO2, SaO2, I don't like saying SO2. The saturation will be what? At any given PaO2, the saturation will be higher or lower if you shift it to the left. Lower. Because it's not going to be, you're not loading, or not releasing any of that oxygen, right? It's just staying put. Does that make sense?
Mm-hmm.
Okay, so it should be lower than normal. And tissue oxygenation is impaired because we are not providing any oxygen to those tissues at that point. Okay. Does everyone have those filled out? The top part? Okay. In the lungs, a blank affinity is desired.
High.
A high affinity, because we want to hold and load it. Does that make sense? Loading it is going to be a high affinity. I know, it's a hard concept. And at the tissue level, we want the affinity to be decreased.
Was the significance just like for supplemental oxygen? Sorry.
Say it again, I'm sorry.
The significance of this measure for the P50? for
Yes,
the
or that supplemental O2, and also and it could increase or decrease depending on the shift.
Because you want a high affinity because you want to hold it in the lungs, and then at the tissue level you want to release it so that's why it's decreased. Released.
Okay, does everyone have this somewhat down? Okay, I know, it's a lot. I was there, I think I skipped one. Okay, because we're gonna move on. It's still talking about some of the shifts and stuff like that, but we're moving on to some effects of what we're talking about with the shift. So, the Bohr effect. The Bohr effect is talking about the effect of PO2 and pH on the oxyhemoglobin curve. We already talked about some of these, right? I think I meant, yeah, no, it says PCO2. Okay, so the first blank says blank PCO2 does what to the hemoglobin saturation? So this is going to be, I have to tell you pretty much because it can go either way. So an increase in PCO2 does what to that oxygen hemoglobin saturation? So remember, pH, if it increases, it shifts to the left
To the left.
because it holds on to it. So what is it going to do to the saturation? Does it increase or decrease that saturation?
Wait,
Say this one more time, right?
That's okay.
why would it shift to the left?
Yeah. Say that one
Because
more
it's
time.
increased PC.
Oh, I'm sorry. I said pH over here. Increased PCO2. I am so sorry, you guys. Okay, so an increase in PCO2 does what to the pH? It decreases it.
Decreasing
And what does it do to the oxyhemoglobin saturation?
it. It's gonna. It's gonna.
Decrease.
So I guess let me say this a little different because it's there's a middle step here that we're not saying, that it's saying shifts to the curve to the left. So if I have an increase in CO2, okay, what happens to our saturation? Does it go up or down?
Down.
It goes down, right? Our overall saturation will go down if we have an increase in CO2, okay? So what does that do when we have an increase in CO2 as far as the shift goes?
To the right.
It goes to the right and releases that O2. Does that make sense now? Increased CO2 is going to cause our saturation to decrease, okay? And ultimately shift the curve to the right.
Wait, but remember when we were talking about burn victims and we said that it would make the SpO2 go read higher?
That's carbon monoxide.
Oh, okay,
A
never
little
mind.
different. That's okay. Okay. Makes sense?
It's gonna decrease the saturation and then push it to the right.
Yes.
Decreased levels.
So then, if we have decreasing PaO2 levels, which way is it shifting, left or right? Remember the PaO2 is the bottom number. If it shifts, if we're decreasing PaO2, it's gonna shift it to the left. Yes. I heard you. I was just making sure everyone, you got it. You got it right,
No,
girl.
I didn't.
To the left. Okay. That's the Bohr effect. And at the bottom, this is really happening most active in the capillaries of working muscles such as the heart, the myocardium, okay? So this is the Bohr effect. It's saying, this is what it's saying. This is what it states happens when they talk about PO2 and pH in the oxyhemoglobin curve, okay? The Haldane effect, okay? So the effect of O2 on CO2 uptake and release. Okay, so we're talking about CO2, O2 and CO2 uptake and release. So the first blank is deoxygenated blood. Deoxygenated blood. So if we have hemoglobin that are open, there's nothing on it because there's no oxygen, it's going to enhance the loading of CO2, right? If you have CO2 and oxygen, which one's going to load on the hemoglobin faster? CO2. So if you have open hemoglobin and if you're looking at O2 and CO2, we know that if you have unoxygenated hemoglobin, it's going to only increase the amount of CO2 that is going to load on that hemoglobin, right? Make sense? So that's what this is stating. Therefore, so the first blank was unoxygenated. Therefore, oxygenated blood enhances the unloading of CO2. So that's what Haldane's saying. So saying pretty much unoxygenated blood is gonna enhance the loading of
Sorry,
CO2.
I'm trying to turn this sound off, and I just got this watch, so I don't know how to do it.
You're fine.
I'm trying to turn it off.
Therefore, oxygenated blood enhances the unloading of CO2. That's all it's saying. Make sense? Pretty simple. But that's the Haldane effect, okay? So, when we talk about our COPD patients, right? And what do they typically have? Increased PaO2s or decreased PaO2s? Increased oxygen or decreased oxygen? Decreased oxygen. Our COPD patients typically have low PaO2s, low oxygen in the blood. And so therefore, they tend to have higher CO2 because they have unoxygenated blood. Does that make sense? So that's why they typically have higher CO2 levels. Okay, I mean, there's a lot of different reasons, but this is where the Haldane effect is kind of coming into play. Okay, so COPD patients are the ones we're really going to see that higher CO2 because they have unoxygenated hemoglobin. So CO2 sees an opportunity and it jumps right on board. Okay, so PaO2 is high at pulmonary capillary beds. So hemoglobin's ability to transport CO2 is decreased. Let's say it again. So at pulmonary capillary bed. So at the pulmonary, in the lungs, right, our PaO2 is high. So is that going to increase or decrease CO2 loading? If we have oxygenated blood, it increases the unloading and decreases the loading, right? So at the lungs, we have a high PaO2, which enhances the unloading of CO2. Does that make sense? Okay. This allows more CO2 to be released at the pulmonary capillary bed. So PaO2 is decreased at the systemic level, so hemoglobin can pick up more CO2. So at the tissue level, reverse it, we're getting rid of oxygen, so our hemoglobin is becoming unoxygenated. So it can pick up that CO2 and take it to the lungs where it can be released. Make sense? So that's all this is talking about the uptake and release of CO2 and O2, which is the Haldane effect. He's the one that termed it, and he was like, put my name on it. That's mine. Okay? Any questions about those two effects? Bohr effect. So Bohr effect, remember, what did Bohr say?
As PCO2 rises, saturation goes down.
Yeah, pretty much, essentially. So an increase in PaCO2 equals a decrease in PaO2. And what does that increase in CO2 do to the shift? Right? If we have an increase in PaCO2, the reason why it's decreasing the PaO2 is because it's shifting it to the
Right.
to the right. And then it also says PaO2 levels shift the curve to the, or I'm sorry, decreasing PaO2 levels, shift it to the
Left.
left. So all of this is the Bohr effect. So it talks about PaCO2. Increased PaCO2 is actually shifting to the right, but decreases the PaO2. PaO2 decreasing shifts it to the left. Okay, and then Haldane is talking about unoxygenated blood. And what happens if you have unoxygenated blood? Increases the
Increase CO2.
loading of CaO2, or CO2. oxygenated blood.
Enhances unloading CO2.
Increases or enhancing, however you want to say that. Unloading. Okay. Got it? I know that's, again, we're kind of throwing a bunch at you here. Did you have a question?
Oh, no.
Oh, okay. We're almost, what'd you say?
I said no, sorry.
No, you're good. Okay, we're almost to the end, guys. All right, cyanosis. You're like, what? Yeah, it kind of goes together, but it's been a while since we talked about cyanosis. So central versus peripheral cyanosis, okay, is kind of what we're talking about here.